Welcome, everyone. Thank you for joining us. My name is Sarah Burris. I'm the scientific liaison here at FUJIFILM Visualsonics. And on the line with us today, we have Dr. Daniel Donner. He is a research officer coming to us from Baker Heart and Diabetes Institute from Melbourne, Australia. And he's going to be speaking about non-invasive measurement of myocardial ischemic zones in the mouse using high-resolution cardiac ultrasound. So just a few housekeeping notes regarding the webinar. A recording of this webinar will be made available. All of our attendee lines will be muted during the duration of the webinar. So if you have a question, please use the Q&A button throughout the presentation. And all of those questions will be answered at the end of the session. Now, our presentation today is expected to last approximately 40 minutes, and then we'll have approximately 10 to 15 minutes of questions. Now, following our Q&A session, we will also have a very brief presentation by our Vevo 3100 product manager, Stephen Butters, just telling you a little bit about the new software that was released yesterday. So about our presenter, Dr. Daniel Donner is a preclinical cardiovascular microsurgeon and imaging specialist. He received his postdoctoral training at the Baker Heart and Diabetes Institute in Melbourne, and he now leads the preclinical cardiology microsurgery and imaging platform at the Baker Institute, which performs procedures and provides research design support for over 40 research projects concurrently. And these are both for internal and external commercial and research partners. So with that, I will turn it over to Dr. Donner.
Thanks, Sarah. Good morning, everybody from Melbourne, and good afternoon to everyone over in Toronto hosting this for us this morning. I want to start off by thanking Visualsonics for the opportunity to speak to you all directly like this about the work that we're currently doing and the this new potential application of the Vevo platform to do something that we previously didn't realize it could do. So I also want to thank obviously the Baker for giving me this platform and the space to work on such an interesting work and share all this with you today. So just to give a bit of an overview of what the webinar will include today, I'll start off with a brief recap of the issues of reproducibility and translation that I think most of us will be more than keenly aware of, and briefly introduce the platform and the procedures that we're specialized in and what we provide to our users and where these issues have been identified that we're trying to correct. And then I'll discuss the priorities in preclinical imaging, and that sort of highlights the importance of sharing these new methodologies or anything like what we're talking about today in a standardized manner to allow everybody to approach it with the same using the same protocols and from the same direction, rather than allowing that protocol slippage without discussing it in this sort of detail that we'll be able to today in this webinar. So then I'll zone in on the problem, which is the confirmation of the ischemic zone following a myocardial infarction procedure. So I'll go into more detail about what the procedure entails. Most of the listeners will be aware of what this is, but we'll talk about the nuances and the different aspects of the procedure that lead to the issues of not being able to define the ischemic zone and confirm homogeneity between groups, which is incredibly important when you're performing drug development trials or preclinical trials in pretty much any space. Then I'll introduce our idea, how we've gone about taking that a step further beyond the idea and conceptualization to validating perhaps just how useful it might potentially be, and then talk a bit about how we'll continue to work in this space in the future. Brilliant. So the issues of reproducibility, this is something that we're all quite familiar with. Obviously, these couple of seminal papers 5 or so years ago, more so in cancer research, but they really did highlight the problems that we face in translating most of these drugs that we're developing preclinically into the clinical setting, to the bedside. Obviously, this is quite a big problem, not just within cancer research, but within cardiovascular research and in preclinical trials of new therapies and so on. And we can see that through any industry presentation of just how much work goes in at the beginning of the funnel at the bench, and how very little makes it to the end. Okay, so I'll briefly introduce our platform and how we operate, to give some context to where these ideas have come about and why they've perhaps come about. So the preclinical cardiology research platform, which is run by Julie McMullen here at the Baker Institute, the head of our domain as well. She oversees all of the procedures in the team here. And what we do as within this platform is we provide a suite of microsurgical procedures. So the myocardial infarction surgery, TAC, thoracic aortic constriction banding, telemetry procedures, and imaging as well, which I'll go into in the next slide. But something that we really focus on and we're approached for externally, so from other partners around the world, is our expertise in the myocardial infarction surgery. So that's inducing an ischemic insult with or without reperfusion. We generally work with models that include reperfusion, since it's very rare that patients aren't reperfused unless we're talking about very late presentation to a hospital. But within the context of a reperfused model, to test different therapies, pre or post reperfusion, generally most of these start off in the knockout models before we progress to small molecules or different therapeutics. Now, the typical endpoints, just to run through this, although most of you will be very aware of how this procedure works and will probably have had this performed in your own laboratories, that the major endpoints are typically infarct size, fibrosis, measures of inflammation, circulating and tissue inflammation, looking at the infiltration of immune cells. We're looking at arrhythmia, but of course, during the progression of the disease, we can assess time course remodeling and functional changes using different modalities from echocardiography, PET, CT. We've got MRI as well. So just going through a couple of those modalities that we typically use here at the Baker. So we have the Vevo system, which we rely on quite heavily for almost all of our projects. So there's quite a lot of projects running in tandem here, and we perform the majority of all these ultrasound studies after the surgical models have been established, which we also established, and we use that Vevo system, as most of you will already, for 2D assessments of geometry and systolic function, Doppler assessment of diastolic function, strain and strain rate, and we have groups here with a particular focus in vascular function and changes in atherosclerosis and so on. We also have quite a large 9.4 Tesla magnet down in our facility, that provides us with some incredible images as well. But we typically rely far more heavily on the Vevo, not just because of the difference in cost and resource allocation, but because we do tend to get quite a lot of quite relevant information from the Vevo. And as we start to play more with this the strain software package, we've come across completely new applications or potential applications. That's exactly what we're going to be talking about today. So just before moving on from imaging, in comparison between the two modalities, so with the parasternal or even if we try to acquire as neat a 4-chamber as we possibly can with the echo, there's quite a lot that we can do with that machine. We can this is just a bit of a summary table of all the quantifications that we focus on. And then, of course, the CMR, which provides quite beautiful images as well, and allows us to perhaps visualize the right ventricle in more detail in some aspects. Its real benefit, or it's what really separates it from the echocardiography, is perhaps more than anything its ability to quantify the scar and allow us to even volumetrically quantify the size of the fibrosis following a myocardial infarction procedure in our different groups. But something it doesn't really provide us with is the sort of nuanced functional changes or the biomechanical changes that now we can assess quite quickly and with an optimized workflow on the Vevo. And another thing that, prior to us jumping into this area as we have, neither of these modalities have really been used to quantify anything like the ischemic zone, which is something that we've realized as a part of our or something that's been needed in order to improve the reproducibility and the rigor of these MI studies, particularly the long-term studies. But before I get into the problem, I just want to highlight how important it is that we're all here talking about these procedures in this detail and providing this forum through Visualsonics to have everyone essentially being able to be trained from all corners of the globe at once. We have a lot of focus at the Baker Institute on reproducibility and translatability of what we do, and there's always that focus of the end outcome and the impact of what we do. Besides the broader approaches to rigor that improve all studies, such as randomization and blinding and those sorts of things that make sure that we're not intentionally or unintentionally affecting the outcomes of our research. We also have quite a strong focus within our platform, since we have this unique opportunity at the center of a lot of different studies to optimize and improve rigor through improving the more technical components of reproducibility. So we've standardized training. So recently, within the last couple of years, we've implemented multiple variants of training for particularly echocardiography. We initially set out to evaluate what was the best approach to this, whether or not it was best to fly people around, fly scientists overseas or interstate and will fly people in to train and sort of standardize procedures that way. Traditionally, as is the case in most institutes, we relied as well on sort of internal, informal peer-to-peer training, particularly in things like echocardiography, and but it extends across the whole suite of bench-side procedures. So things like all your molecular work, that's sort of been traditionally passed on from postdocs to PhD students to honor students and RAs, and sort of sideways throughout a lab without there being, of course, generally a protocol at the center of it. There's this protocol slippage, as it's been defined as, And we wanted to just build on top of that with this internal formal training approach where we can adapt with methodology guidelines and some that are published around the world, and sort of update what we're doing, but standardize it within the institute to make sure that everybody's having or using the same approach to things. And that's what we're going to try to do today. We're going to implement this as a standardized approach, just to really hit home how important it is that we do all take the same standardized approach to echocardiography. This was our first assessment of this was in just M-mode analysis using in our echocardiography systems. And we wanted to assess just how variable the analysis component of echocardiography was. At our institute, we are, just like many phenotyping platforms will operate, we acquire all of the imagery, and then we allow groups to analyze that. And when you do leave the analysis to multiple groups without providing some sort of very standardized framework, then you do open yourself up to there being completely different approaches to that analysis. So we had a quick look at a couple of years ago at just how variable M-mode analysis on its own, which is one of the more perhaps most widely used approaches to echocardiography, just how variable that was within our institute. And we realized that it was surprisingly variable before standardizing that, probably more shockingly variable than we expected, but it was easily correctable through a simple sort of hour lecture and some sort of bringing everybody together, just as we are today, to really go through the details of how we approach the different steps of M-mode analysis the way we do, and that leads to a huge reduction in variability, which we also showed would lead to a considerably lower standard deviation and a smaller animal resource allocation. So had ethical implications and really placed a lot of onus on us to continue with this sort of work, which is why we've really pushed ourselves more in this direction of standardizing procedures like the one we're discussing today. Okay, so there is this one issue with the myocardial infarction surgery, and this is something that most groups will be familiar with. There are a number of ways of approaching the procedure, and there's a number of different periods that you can induce that ischemia for in the left ventricle. So after the ligation is placed in the left ventricle, that ischemic period can be 1, 2, 4, 6, 8, 12 hours, or even permanent. I think traditionally the permanent model was most widely used before attempts were made to learn how to reperfuse the surgery non-invasively without opening up or performing another thoracotomy to release the ligation. But now that most labs around the world are able to reperfuse through sort of releasing loops or different knots and so on, there are far more labs using the ischemia reperfusion model, which is excellent. It's far more clinically relevant model, and it does obviously allow for the perfusion of circulating therapeutics to reach the injured myocardium. The most commonly used, or at least the most commonly requested sort of endpoint after a myocardial infarction surgery is a quantification of infarct size, and that's typically done through TTC staining, which is, apart from being quite a wasteful procedure in terms of the tissue that's sort of lost to that endpoint, because you can't really use TTC stained myocardium for much else, no molecular work or histology really following that. You can't perform a TTC stain at the beginning of say a 1 month or 2 month or 3 month ischemia reperfusion study. So once you've performed the surgeries, there's no way of confirming the homogeneity between the groups that you've allocated those animals to. So particularly for earlier surgeons or for models that haven't been validated or used before, so different strains of animals, if there isn't a confidence in the procedure and in the ischemic zone that you're inducing, then it's quite hard to then invest a lot of time and other resources in continuing that study to 3 months, only to find at the very end that some of those hearts weren't ligated properly, or they had smaller infarcts or really large infarcts. And we sought to see if there was a way of quantifying that, or at least confirming that that had been done homogeneously between all the groups. Now, just some other things to be aware of when we're talking about ischemia reperfusion surgery. So the area at risk, or the ischemic zone, so the same thing. The larger that area at risk is, that the larger that we typically get an infarct. So it is really important that area at risk is homogeneous between the groups. Otherwise, we do, although it's corrected for, or infarct size is corrected for area at risk, and it's presented generally as a percentage of area at risk, it is important to make sure that area is the same between all your groups. We also know that the longer that you maintain that ligation over 1 to 4 to 12 per minute, the larger that infarct becomes as a percentage of that area at risk. And perhaps most importantly, although we perform many of these procedures with close to a sort of a 95% and typically above success rate with MI, with all of the animals recovering very well, the area at risk at the end of 2 days, once we remove these hearts and do perform the TTC staining, no matter how many we do, the area at risk is always going to be quite variable, especially when you have multiple surgeons performing the procedure. So here, ideally, we'd be, if we were able to only treat this internal or smaller cluster of animals and reduce the chance of spending all of our time and taking animals out to 2 or 3 months on these animals, then perhaps there's it's worth considering this method that we're about to talk about. So it is really important that we have some sort of exclusion criteria set up before the procedure. If we're going to use this method, that all has to be assessed post hoc, but I'll bring that back in the summary at the end. But the big issue that we have when we're performing the MI procedure is that an MI causes such severe thinning of the left ventricular wall, as evidenced by this dissection of the heart afterwards. It's quite clear what that thinning looks like and how, or where that ischemia and infarct has been induced. Visibly, it's quite easy to see through this sort of planimetry. But that's only with permanent ligation. When you do reperfuse, and typically it's the ischemic periods are anywhere between half an hour to 45 minutes, an hour, most typically. It's far less evident where that infarct is without counterstaining with the TTC and showing the red, blue, and white sections with TTC. So for those who aren't familiar, the blue zone here is typically any blue dot, but Evans blue is the stain that we use here, and then the TTC and the TTC highlights or discerns between the infarcted and non-infarcted or ischemic zone. So zone that's been ischemic but not necessarily, or still viable, is still viable tissue. So the quite stark difference here means that when we're looking at an ultrasound, we can see this quite clearly. We can see where the wall's quite thin, but not so much in a 1 hour occlusion. So here, when we look at the histology of these sorts of procedures, we have the sectioning here shows that this is the level of the ligation, so we can see where the actual ligation's gone through the tissue behind the left anterior descending coronary artery. This is the slice about 120 microns below this slice here. So we can see that all this damage is quite regional at the level of the ligation and below towards the apex, but above that ligation. So this is just the next slide up. We serially dissect these hearts. This tissue looks quite viable and thick and is still quite functional. But when we look at the ultrasound, it still doesn't show up as loudly as we'd perhaps expect. So with no injury here, so these sham animals here, we can see the closing of the left ventricle quite clearly. With permanent occlusion, we have this apical ballooning, which is very easy to identify and trace. But when we come back here to the temporary 1 hour occlusion, it's we can't really see where that ligation's been placed. When we compare it to something like this sham, that they look fairly similar, apart from some increase in size. So this is at 24 hours, these assessments. So there's quite a big difference between the three. And again, when we're using these models, the temporary occlusion model more commonly than we're not really able to confirm that we've actually performed that surgery correctly unless we take another step. So that's where we bring in the strain software, which is quite a powerful piece of software that Vevo has made available to us. The strain allows us to track that endocardium and with a very high temporal resolution, assess the displacement, velocity, and strain in that along that endocardial surface. So when we look at strain in an IR model, I mean, the differences are quite obvious. But what we're actually doing with this software for the confirmation of homogeneity of ischemic zone, because we're actually using another tab within that software. Instead of looking at strain, we're looking at displacement of the tissue, just raw displacement, because the relative mapping of that displacement in the software allows us to really see the sort of the segmental or temporal changes in where that when that tissue or that part of the tissue is moving. So initially, all we wanted to do with this software, or all we really wanted, was to confirm that following the procedure, once the ligation is placed, as soon as possible, so within the first 24 hours, we wanted to know whether that ligation has been placed correctly, and we have induced a transmural infarct. And we also want to know roughly whether or not that ligation has been placed in the same place across all of the animals, all of the subjects in each group. So that was where we wanted to start this. And as soon as we did, we've tried multiple approaches, so different intersections of the left ventricle, tried short axis, everything from short axis strain, M mode, a lot of different approaches to see which are the best and the most reproducible and the most confirmatory of all the different assessments we can do. And we've come to find that the most dependable approach is this displacement method. So I'll show how this is all done in detail as well. But what this is showing here is that in the sham we have, when we track that endocardial border, the entire endocardium displaces relatively uniformly from aorta to aortic root and the anterior to the posterior. And that's what this heat map is showing here. So this is from aortic root to aortic root. The the relative displacement along there. And then in our 1 hour ischemic models, where we have still contraction along the entire wall, and if we were to drop M-modes across different sections of this ventricle, we would see that everything is contracting, perhaps not uniformly, but still contracting. When we do use this powerful strain software, we can see where that cliff drops off and where that location has been placed, because this assessment gives us a relative display of the endocardial displacement. And then when we flatten this three-dimensional image out, we see that cliff, this entire zone in here, which was a bit of a surprise to us. This correlates perfectly with the ischemic zone when we perform those traditional methods of assessing that with TTC and so on. So this is the approach here. So whether or not you have the 2100 or the 3100 Vevo system, the approach is the same, obviously, with the 3100. The lower profile probe allows you to do quite a bit more with that. And there's a lot of benefits of the 3100, which I won't dwell on too much. But the main point is that if you do still have this 2100 system, you can perform the same procedure. So this is what we call the side view of our mouse or our heart. So we're tilting the mouse and the probe 20 and 50 degrees respectively. We don't perform a full study here. So this is 24 hours, again, after the ischemic or the ischemia reperfusion surgery has been performed. We anesthetize the mice with a volatile anesthetic, something that's going to be reduce the chances of additional complications, something that the animals recover quite quickly from. We really aren't interested in diastolic function or even systolic function in these studies. This is purely to confirm the ligation height and the homogeneity between groups. So this only takes a few minutes to set up, to place the mouse on the stage and have the probe ready. We take our imagery and our cine loop, and then we perform all of the analysis post hoc. So the animals aren't down for very long, and they recover well. They're back in their cage and also recovering from their surgery. And then once we've performed all of those procedures, we can go and open up the strain software, and this is the process of how we perform this homogeneity assessment. So we choose the images with the clear endocardium. We make sure that when we open that strain software, that the endocardium is being tracked properly. That's one of probably the most important steps, regardless of what aspect of the Vevo strain software you're using. Making sure the endocardium's being tracked throughout the whole cardiac cycle is very important. So all this imagery, by the way, is just using one loop for the sake of showing or demonstrating the software and the approach. Typically, you can include a lot of subsequent cardiac cycles in your analysis, in which case you'd have this sort of shrink, and you'd have sort of 5 or 6 cycles perhaps fit in here across this timescale. The timescale being horizontal. So here we've got the beginning of the trace. So we trace from the anterior root all the way through the apex down to the posterior root, and that we confirm through just playing the cine loop to make sure it is tracking, and then we get this displacement heat map on the side. So in this map, just to orientate you again, the time scale is from left to right with the ECG superimposed on top, and then we have you'll see these depending on sort of the I'm not sure if this will ever change with the software, but these green lines, so these are the gradations or the measures, essentially a ruler placed in around the entire endocardium. So we have, I think, 6x4 ticks here, 24 marks or 24 gradations, and very clear halfway marks in those gradations. So essentially about 48 points. So we have a resolution of about 2% when we're measuring from the aorta to the aorta, how much of that endocardium is functioning or displacing early and normally, and how much of that's displacing late due to the secondary recoil of the tissue down here. But we get this zone in here measured against that ruler, where you can assess this as a percentage of the entire distance from root to root, and that gives us our ischemic zone. So if we do see an animal without this area, or with the tiny little blue patch in the middle, or something that's atypical, so sometimes you can induce ischemia, find that the surgeon might grab the wrong artery or a different branch of the main vessel, and then you'll see a very atypical shape here, in which case you shouldn't really be including that in your trial. So this allows us to very early exclude the animals that will have very little value going forward. So we don't want to place any sort of unnecessary surgical recovery burden on animals when we can't use them. So this has ethical implications, reducing the impact on the welfare of the animals as well. So what we did beyond that, we were quite interested to see how this related to the dissection method of gravimetric analysis of assessing area at risk. So at our institute, we perform TTC, gravimetric analysis of the ischemic zone or infarct, and there's also this visual assessment of infarct size, which is quite common around the world as well. So we compared, firstly, we compared both this mapping technique against the weight dissection, a gold standard, and found that there's quite a strong correlation in those values between our ischemic zone and the ischemic zone being dissected at autopsy. And when we compare that to the visual approach, which again is very, very common, they're quite identical in their value. The only difference between the visual assessment and the mapping assessment is that, again, you have to dissect and terminate the study and dissect that animal to then make a visual estimation of infarct or ischemic zone. So this is something we can perform without terminating the study, and perform it at 24 hours early on, and allow the animals to continue throughout the rest of the procedure, knowing full well that we have a homogeneous grouping of ischemic zone. So this is the calculation for the infarct size. There is a correction factor that we've used to account for the fact that we're taking a two-dimensional slice across the left ventricle, and obviously the ventricle is three-dimensional, but at least in the animals that we routinely use. So this is, and I'll highlight this in the limitations of what we're doing here, but at the moment this is being performed in C57 black 6 mice. This is the correction factor that allows us to predict produce the ischemic zone as we would at dissection, but non-invasively, again, through the echo. So the future of what we're looking at doing here is validating this method across multiple different approaches to assessing the ischemic zone. So this is some histology from our platform, and some planimetry of TTC. So we are looking to validate using, or validate even further using sort of radio fluorescent or immunofluorescent beads, which is a technique that's becoming more popular in some studies. Validating against this TTC method is almost a step backwards when you consider that the resolution here of, when I say resolution, I mean the number of slices here. When we perform a TTC stain, but we're trying to compare a new method that has potentially 2% resolution to something that has more than 10% resolution. So we have about 7 slices here. This is never going to give us a anywhere near the same area at risk or volumetric analysis that the echo or the ultrasound now might be able to. So of course, this is one of the golden standards as well. So we're just finishing some work now that will compare this method against all of the other all of the emerging methods for assessing area at risk. But we do think that this is going to perhaps be the most utilizable and the most valuable, being a non-invasive alternative to anything that requires dissection and staining, and that's going to persist regardless of the method that we're trying to confirm it against. But I think for the sake of all the groups that do rely on these other methods, they'll all want to see how that all compares. So before I summarize everything, I just want to take this last minute opportunity to thank everybody at the Baker Institute that allows us to perform this work. So everyone from our director and domain head and platform head, the members of our team here, Helen Kyriatsis, Asha Brown and Xiaoming Gao, and I really want to thank all of the people who've supported this project and this methodology. We've presented this now at ISHR in China and here in Australia, and that's getting this methodology out there has been in no small part possible only thanks to Visualsonics as well. So just to summarize everything that we've spoken about here, so the method is something that provides us a validated value of ischemic zone at 24 hours post surgery, and allows us to confirm at the very least that the ischemic zone is relatively comparable between groups, and make sure that we have a typical ischemic zone and a successful ligation in those surgeries. And when you start to think about where this might have its most valuable applications, we use this now to confirm routinely in the majority of our projects here at the Baker. We use this now for training as well. So it does really improve the workflow of your training of new surgeons, making sure that without culling or without terminating experiments early and wasting precious resources, we can train with a much faster workflow. But the real value is in the exclusion of subjects early in a study, the animal welfare implications, of course, of that, and the resources that we save pursuing or continuing studies in portions of projects or cohorts that aren't going to provide any value down the other end, especially if you consider the example of taking a project from the surgical starting point, which might not be the starting point if you have aged or sort of a genetic model already. But once you start that surgery in the beginning all the way through to the endpoints and perform all of the bench work that you plan to perform without having any way of validating that surgery has been performed properly, you can start to count all the resources that can potentially be wasted when you're not checking that sort of thing. And so it's a hugely valuable assessment when you're looking at chronic studies as well, where you're aging mice out after the initial procedure. But again, the limitations at this stage is that we're performing this in a C57 Black 6, and we haven't performed this in other strains of mice with perhaps different vessel anatomy. And that's something that we want to pursue in the future as well, because there are definitely stark differences between some strains at least. the comparisons against the sort of the future directions that I discussed just in the prior slide, and there is potential for early drug effects. But the beauty of the relative displacement map is that even if you do have improved displacement throughout the ischemic zone, the relative displacement map still highlights that as less displacement, so to speak. So there's, even when you do have improvements from a drug or a knockout model, you still see that drop off in the cliff. So with that, I'll thank everyone for the time. I think we went a little bit over the 40 minutes, but I'll throw it back to the team for some questions.
Great. Thank you so much, Daniel. We do have several questions that are rolling in. First question that came in is, can you comment on what the imaging rate was? Was it enough to detect subtle changes and variation of displacement and strain expected in your reperfusion model?
Sorry, just the beginning of that question again. Sorry, Sarah. Was that the
yeah?
rate?
Can you? Yes, please comment on the rate of imaging.
As in the frame rate within the imaging? Is that sorry that?
Yes, that's what I'm assuming they're meaning.
Sure. Yeah. So when we're acquiring anything for strain analysis, we're wanting something in the sort of 280 frames. I think it's 279 is the very specific number that we try to acquire at. So that's with a width of about 10 mil, or depending on the probe, of course. I think that's with the 550. But there are requirements for the strain software for a fairly high frame rate in order to track the endocardium properly. I think that the more recent version of the software, assuming that the latest version that you're announcing today still performs this. I think it does from talking to your team. You can use EKVs as well. We do use EKVs now for this strain tracking, which allows for a very high frame rate and then a very clear tracking of that wall if you have that EKV package, which I would recommend you invest in. But the about 280 frames if you're just using the raw imaging.
Great, thank you. Daniel, do you know, is there actually a cutoff for a frame rate, meaning that if you didn't at least acquire at, let's say, 220 frames per second, it would not be sufficient enough to detect these subtle changes? Have you done any of those experiments?
We have. I don't think I've never asked. Your team probably has a better answer for that, but I'm pretty sure the standard imaging, the long axis loop that's in the standard preset is, I think that's under the threshold. So you do need to modify, and this is again with the 550 probe, but I think it is about 250, something like that, that you want to get above in order to import that into the strain software.
Fantastic, thank you. So Daniel, can you comment, this is referring back to the formula used for the infarct sizing. Can you comment what the ZRWD is in the formula?
Yeah, sorry, thanks. So this is the relative wall displacement. So the zone of the relative wall displacement. So taking on the, let's have a look at this. So this is the map. So when we're using this ruler to assess it, we're looking at the total displacement, and then the portion of the wall with zero wall displacement, essentially. So when you have this blue section in the middle, so you'll see that this shifts shifts with every ligation. So with a smaller ligation or a higher ligation, you'll see that the basal interior heat is thinner, and we see that this opens up. Generally, the higher the ligation goes, the more widespread that ischemic zone is, and it really blocks quite a lot around to the right ventricle here. So we see this sort of expand in both directions, that the higher the ligation. But yeah, the lower the ligation, you can sometimes see, and if you miss the artery altogether, you'll see that these little, like a tight band of blue of zero relative wall displacement, and that's obviously not what you're looking for. That's what that ZRWD is, the zero relative wall displacement.
Perfect, thank you. So when performing strain mapping, can you explain why you use the displacement map rather than just strain mapping itself?
We have looked at strain. We've had a look at all the different parts of the software, but this strain's looking at a completely different aspect of this endocardial biomechanics. So the displacement's really the most robust in that it's just tracking the raw displacement rather than the tension or the movement between different points along the endocardium. So you with strain you do get this a fairly similar a similar product, but the displacement's what gives you this absolute drop off at the ligation site. And when we see the ligation, which you can't rely on in echo, but if you do see the ligation point, this is not what this is necessarily, but if we do see the suture or the pillow that we use on top, that always drops right on top of this this zone here in the displacement map, but not always in the strain map, because again you've got a partly viable tissue in here. So depending on what a drug's doing or a knockout model's doing, some of this tissue is still quite functional, so you'll still get strain value out of this tissue, but again the real drop-offs in this displacement, this longitudinal displacement here.
Mm-hmm. Daniel, can you comment? You have some very nice, clear B-mode images here that seem to not really have a large scar formation. Now, I realize in your ischemia reperfusion, that's just potentially 24 hours after the ischemia reperfusion surgery. But we have a question is, how do you avoid artifacts due to surgical access?
Sorry, in relation to these B-modes being quite clear. So you've got
right. So, and a lot of times we can see some big kind of black shadowing that occurs in post-coronary ligation models. And you don't ever seem to really have that in the examples that you show here. So I think some people are just looking for a few pointers maybe for the surgical aspect.
Sure. Okay. So with I mean, these are quite clear B-modes. You know, we use I guess we've used some of the nicer ones here, but even with the shadow that you typically get with an IR surgery, it tends to drop right at the apex too, depending on obviously the age of the animals and their size, and where you've sort of left the heart after the procedure, hopefully back in its original spot, especially if you can keep the pericardium intact, that makes a big difference. But if you do get shadowing at the apex, which is quite common in those procedures, it doesn't actually affect this too much. You can actually see it quite clearly on the map as well. Sorry. So if you do get that shadowing, generally it falls within this space here. So this is pretty much your apex right in the middle of the map. So as long as you've got this ischemic zone is being measured beyond that, then you can be quite confident that you're measuring the top and tail of the ischemic zone, so to speak, beyond the shadow. We do take steps to minimize the risk of that shadowing by entering or opening that portal to the thoracotomy quite high, and then when closing the ribs, trying to maintain a sort of a semi-tension to make sure that you're not closing ribs non-visual, together too much to create a huge band of two ribs that then drops obviously a large shadow. We just want to make sure that you're closing firmly enough to maintain the pleural pressures, but not sacrificing the quality of the echo afterwards, but just making sure there's a little bit of distance between the ribs in closing. Other than that, just specifically we're using a 7.0 suture, silk braided for the ligation, 6.0 prolines for the closing, which is probably quite typical, but that's what we use anyway, just for those interested.
Great, thank you. So Daniel, we realize you've probably maybe only done this on an ischemia ligation model, but someone's asking what the feasibility is for potentially using this on a fibrosis model, specifically in the right ventricle. Do you think this is a suitable method to look at that model, or would something like cardiac MRI be more appropriate?
I think when quantifying fibrosis, you want to be using something, at least in the non-invasive context, you'd be looking at something more like MRI and LGE, some sort of contrast enhancement of the fibrosis. Interstitial fibrosis, I think, is far a little more difficult, at least. The problem with models of diffuse fibrosis, I think, that they're not, unless you're really trying to, or really expecting a regional fibrotic lesion of some sort, or something that's really going to affect regional tissue function, I don't think you're not going to see or be able to use this sort of approach to assess that. But if you do have something else that induces scars, theoretically, if you were to inject perform an intracardiac injection of something that causes scar, and then you have lesions, this is a sort of approach that might be relevant for those sorts of models as well, to quantify just how much of an injury you've caused, essentially. So it might be applicable in those models, but in terms of assessing the actual fibrosis, I guess that's probably best in MRI, or at least it might be worth comparing in such a model what you find with this approach compared to the MRI and LGE.
Yeah, great. And just in keeping with our time, we really only have time for one more question, even though we've got several here that we will attempt to answer after the webinar is ended. Sure. One is, the GLS number is really a common parameter that most people report when they're looking at strain values. So how do the strain maps shown compare to the GLS number? And is this a common clinical metric?
What we're looking at here, this displacement metric, is not common at all. I don't think it's really used for much other than just making sure that you're tracking the endocardium properly. But it doesn't really relate to the GLS, the global longitudinal strain. So, I mean, strain is more. You're visualizing strain more with these arrows almost. Well, not so much the arrows, but the movement between the points. With the displacement mapping, these little green loops show you that where the endocardium's moved throughout that cardiac cycle. So you can see that that sort of visualization of what we're looking at here, and that's very different to really the strain. This is a completely different visualization compared to GLS, but again, no, it's not a clinically used, or not in my experience, a clinically relied upon metric. But GLS is definitely more common and has its applicability in most studies as well when looking at endocardial strain.
All right, thank you. Well, fantastic, Daniel. Thank you so much for the presentation today, and I thank everyone who attended. If you still have a few more minutes to stay on the line, we have just a very brief presentation by our product manager, Dr. Stephen Butters, who will be discussing the new release of the Vevo Lab software. So with that, Stephen, I'll let you go ahead and take over.
Great, thanks, Sarah, and great presentation, Daniel. Really interesting work that you're doing. Great to see that.
But you have to take it back.
So we're just going to get sharing from the desktop switched over to my side, and I know I'll be conscious of everyone's time here. I'll try to keep this brief. So we've got some great new tools that have just come out, the access to some tools that have just come out in a software update for the 3100 and laser platform, and also for Vevo Lab that we've just released. And these, I think, really speak, some of them, to some of the things that Daniel, that you talked about on your presentation about standardization and trying to limit inter and intra-operator variability we've developed a set of tools for LV analysis that use artificial intelligence. This is our Auto LV product. It's very reproducible, based on a machine learning algorithm that's been trained with a couple of thousand traces across different animal models, different species. And it uses the manual LV analysis tool that many of you will have already used in both M mode and B mode. In B mode, it's based on that widely accepted Simpson's method. It gives you all of the standard functional parameters that you've come to expect from the manual LV tool, plus LV mass in the M mode option. So I've got a couple of videos here just showing the first B mode tool at work. So really, you're just finding the spot where you want it to start, and then just going ahead and clicking that Auto LV button. And it will, depending on the options that you set in the preferences, will take your image, compare it against the library, and then very quickly give you a report back with all of those functional parameters in your tracing. And then, of course, the tracing can be adjusted as well. If it's not quite 100%, you've got the flexibility to make some adjustments afterwards. So the B mode tool is really virtually a one-click solution. The M mode tool is slightly different, just because of the nature of M mode in the short axis. You do have to find the range that you want the tool to trace. Go ahead and select that range, let it go, and again, very quickly, it will compare the walls against a library of traces, and will give you back a report at the end, showing you again all of those functional parameters that you've come to expect from these tools on the manual side. So, as I said, both very fast, very reproducible, and they eliminate some of that variability that we typically see with the manual tools. These are both available for purchase. They're a licensable option in the Vevo Lab workstation. They're not on the system, on 3100 system. They're only in Vevo Lab. And they do also work with data, even if you have a 2100 or an 1100 system, some of our older platforms, these tools, the Auto LV tools, will still work just fine with the data from those platforms as well. So it really does go across the platforms. Another great tool to really support and expand cardiovascular research that we've just brought out, this goes with our photoacoustic platform, our Laser X platform. This is a photoacoustic EKV mode. So this is using the physiological parameters that we're getting from the animal, gating, triggering, processing, and giving you really high frame rate cardiovascular images of the heart with photoacoustic data attendant. So you can see here oxygen saturation, the red, white, and blue map that's here showing oxygen saturation in the myocardium. And it's able to do that again just by all the processing tools and sorting, batching, and trying to match up with the cycle. Works well with the heart. It's very fast enough to work well with the heart. Also, as you can see here, works well with the vasculature as well. So if you're looking at, say, atrial models, oxygen saturation in vessel walls, intima media, things like that, there's lots of options there. So anything really to do with myocardial oxygenation, hypoxia, infarct sizing, angiogenesis models, those sorts of things, this mode can support that. So both the Auto LV and the PAEKV mode, again, they are now purchasable options, and they're enabled by this new 3.2.5 software for the system and the lab, which is available from our website. And for those of you who already have a 3100 or a lab, even if you're not interested in those tools, please do upgrade your software, because in addition to those new features, there's always tons of fixes and updates and improvements in the software. And so I highly, highly encourage everybody, regardless of the options that you have activated on your system, do grab the updates off of the customer resource portal and go ahead and apply them to your system. While you're there, you can check out the Learning Hub. We are building up a library of videos to show users how to do some of the cardiovascular acquisitions, cardiovascular analyses. We're always happy to take suggestions for things that you want to see on the Learning Hub and try to really build that out with some more tools and videos that can help with knowledge transfer and help with training. That's something that Daniel touched on in the beginning of his webinar, which I think is really, really important. That training aspect and the knowledge transfer aspect within labs is really critical to getting good quality data. Some other great stuff on our website while you're there too. There's forms where you can submit questions to us. You can register for any upcoming webinars and view past recordings. We do record our webinars, and this one is being recorded, and the recording will be posted. We're active on social. We've got Instagram and YouTube channels up and running, along with various other social panels. And we've got a great list on our website as well of all of the conferences and meetings that we're at. We're always out. We do go to a lot of trade shows, conferences, and society meetings. So if you're going to be there, if we're there, stop by the booth, talk to us, ask us any questions. We always have scientific staff on hand and to support your any questions. There's also our travel awards on the website as well. If you're interested in submitting an abstract to us, we do give away money, a check for $1,000 for the winning abstract to two now. It's for multiple conferences and just to support researchers like yourselves going out to these conferences and sharing and learning. Thanks so much for your time. And again, please do visit the website and connect with us, and we'll see you on our next webinar.